that have the potential to damage DNA. So these can be generated indirectly using a machine called a linear accelerator, or a Linac, and this is the most common form in which we deliver radiation now, where a high energy beam is emitted and shaped using a collimator, which is called a beam shaping device. And I'll show you what a collimator is. Now, radiation can also be generated directly through the use of a radiation source like cobalt. In fact, the use of cobalt for radiation and medical application is an innovation that started in London, Ontario, and it's a Canadian-based invention. So now the source emits the beam of radiation and the beam is shaped using a collimator. This is a fundamental aspect of how gamma knife technology works, but ultimately all other technologies have phased out of radiation sources because a lot of the safety issues and some of the issues in terms of advancing radiation therapy delivery that we can do with linear accelerators. So Linacs are the main form of radiation technology. And this is what a Linac is. And so you can see here in the head of the machine, the radiation gets emitted. And these machines have become so exquisitely advanced that we have major innovations on these machines, like a CAT scanner that's actually built onto the linear accelerator itself. And I'll show you how we use that later on. So how does radiation damage cells? Well, the aim is the radiation goes into the body, it's interacting with the cells of the tissue, and it's cutting up DNA. And the whole point here is to cut up the DNA into fragments. So when this DNA is cut up, it cannot repair the damage induced by the radiation. So for a cancer cell that's trying to repair itself, what happens is it goes to the DNA machinery, it says let's replicate, but that machinery is no longer available, and so it dies when it tries to replicate. And so this is fundamentally how radiation is causing tumor cell kill. So DNA damage certainly is the aim of radiation delivery. Now for tumor cells, they cannot repair that DNA damage effectively, so they die when they attempt to divide. But still, some can repair that damage, and that's why we can't cure all cancers and why cancers still come back. But radiation is very effective in the sense of killing a large proportion of cancer cells in what we treat. Now, one of the common questions is, well, what about all the normal tissue? The beams are coming in and out. What's going on with that normal tissue? Because that's also seeing the radiation damage. So part of the reason why we can't cure all cancers, but we can treat effectively, is because we're limited by the normal tissues. And the normal cells are different than cancer cells in the sense that they can repair that DNA damage. So the radiation interacts, it's causing the damage to the cells. The cancer cells can't fix it, but the normal cells can fix it. And this is why radiation is safe to deliver. But not all the normal tissue cells can repair that damage. And just the same way that not all cancer cells, that some cancer cells can repair the damage, with normal cells, some of them can't repair the damage and you get toxicities. And that's the fundamental difference between the two. So when we are deciding how much radiation to give, it's a balance between how much radiation is going to cause the cancer cell death as opposed to the normal tissue cell death. Now for glioma or primary brain tumors, this is highly important because our aim in glioma, when somebody comes with a glioblastoma, say, is not to treat just that abnormality that we see on the MRI, but it's to treat about 1.5 centimeters beyond what we see. Because we have learned that about 90% of the cancer cells live in that 1.5 centimeters beyond the actual cancer on the MRI. The other 10% maybe over here, maybe over here, we can't treat the entire tissue, but we can treat a reasonable amount to put the tumor to bed. And that is our goal in terms of treating effectively these cancers. And hopefully the chemotherapy drugs are working on the other small cells beyond this 1.5 centimeter radius that we cannot treat with the radiation. And this is why when we deliver radiation, we have to think very strongly in terms of how much dose that normal tissue can tolerate, because again, these microscopic cells are living in the normal tissues beyond the actual tumor. Now, for the radiation approach, fractionated radiotherapy for primary brain tumors is the most common form of treatment for tumors like low-grade glioma or glioblastoma, and essentially we deliver the treatment over 5 to 6 weeks. And this approach of fractionated radiation delivery is because this is what's safe on that normal tissue. So when the aim is to treat not only the visible tumor, but also that surrounding normal tissue where the cancer cells reside, we can't give the radiation all in one big shot. Otherwise, all that normal tissue would essentially crumble and there'd be major toxicities. So by dividing it every day, we actually let that normal tissue repair itself while the damage accumulates in the cancer cells. And this is the principle of fractionated radiotherapy. So the best chance at eradicating the most tumor cells is to deliver the radiation to still a rim of normal brain tissue, and 1.5 centimeters is typically what we aim to treat, and it's biologically best for normal tissues to be exposed to 25 to 30 treatments, as opposed to say 1 to 5 treatments, which is more in keeping with radiosurgery, because it allows those normal cells to repair itself from Monday to Tuesday, Tuesday to Wednesday, while the damage is still occurring in the cancer cells. So this is why we deliver various radiation scheme over several weeks. And most commonly, when we're trying to be as aggressive as possible, we're delivering 50 to 60 grayer units of radiation over 5 to 6 weeks. Again, it's used to maximize tumor control with an acceptable level of side effects. Other schemes include 34 to 40 gray over 2 to 3 weeks. So this is a shorter course. And we deliver this mainly in the elderly population, because putting patients who are 70 or 65 through 6 weeks of radiation can be really quite difficult for these patients. And the tumors tend to be a little bit more aggressive, that these shorter courses can still extend life, but actually get through treatment. Because the worst thing that we can do is actually not get someone through an intended course of treatment, because it really works by delivering the entire course of radiation. So these 2 to 3 week or 3 to 4 week schemes can be pretty effective, but still when we're trying to give somebody the most as possible right now, we're going for a 6-week course of radiation. Now other schemes like 20 to 30 gray over 1 to 2 weeks, these are really quite palliative regimens. So here, the way that I explain it to patients is that we're not trying to extend life per se. We're just trying to temporize the situation, give some radiation so things are under control for the short term, and then allow time for whatever goals that people want to achieve are met. So in the short term, a family coming or traveling, this can occur by putting the brakes on the tumor for a short period of time. So this tends to be more palliative. It temporizes or relieves the symptoms in the short term, and its aim is to minimize side effects. So we're not taking the risk of accelerating life for side effects. Here we're trying to minimize potentially the therapeutic impact, but while minimizing side effects. So I wanted to go through the radiation process. So at the first appointment, you meet the radiation oncologist, the medical oncologist, and you meet the entire team, in particular our social workers, potentially physiotherapists or occupational therapists, depending on the clinic, and everybody kind of weighs in terms of offering support and advice and resources. So most meet a social worker to ensure that the patient is not missing any of the required resources to help you through this journey, because it's so much information right at the beginning. And this is why one of the primary sources of information in our clinic is the Brain Tumor Foundation of Canada handbook. So all patients get this, and is an excellent resource for our patients. Because most of the time, people are not remembering much of the information beyond if we have to explain to them the diagnosis, if that hasn't done occur, and then everything to do with radiation and chemotherapy is just overwhelming. So we really do appreciate this resource. So the next step, so once it's decided that we're going to give radiation, the next step is radiation mapping. And this is a step called simulation. So a few days after the consultation, we need more imaging in order to plan the radiation. So a special CT scan is done, and we need our own CT scan for radiation mapping. And you need an MRI so that we see what's happened after the surgery. And we use this information together in order to plan radiation. Now, at this stage, we also have to make sure that people are in the same position every day that they're going to go on for radiation. So a patient-specific mask is made so that people stay in that same position in terms of the head position each day. So this is what it looks like. So you can see here we have our own CAT scanner. It's a little bit different than a diagnostic in the sense it's very large bore in nature. And we create these masks that make sure that the head position is in the same position every day that comes in for treatment. Because remember, we're talking about 6 weeks of radiation every day, Monday to Friday. So the head has to be aligned in the same position as when we did this step in the mapping. So the next step is planning. And typically up to a week is required to plan the radiation. So behind the scenes, the radiation oncologist, the physicist, the radiation therapist, I mean, there's a whole workforce of people working on radiation planning behind the scenes to make sure that we have the right plan for you. And this is what a radiation plan looks like. So here we're trying to cover the target, which you can see here in orange color wash, and we're delivering a dose of 60 gray here in red, and it encompasses the entire tumor. And so we need to treat effectively as much as the intended target as we can while minimizing as much brain tissue as possible. Then the third step is treatment. And here, typical radiation treatments involve 3 to 6 weeks of radiation. Again, it's every day, Monday to Friday. We don't treat on weekends to give people some time to heal, because if we did it every day, 7 days a week, it would simply be too toxic. Now, each treatment takes about 30 minutes. And it gets better as the time goes on because everyone's more familiar with the process, and the therapist and the patient, everything goes a bit more smoothly. So what are the side effects? So during the radiation, there's tiredness, fatigue, hair loss, skin may become a little bit red and peel like a sunburn. There's always potential for headache, nausea, vomiting because of inflammation of the brain tissue, and we have to adjust the steroids. It's unpredictable, it's empirical, and we have to basically use our judgment in terms of what dose to use. Now, 1 to 3 months after radiation, this is where a lot of the times that fatigue is kicking in. And there could be a lot of tiredness, in particular for patients who are older. And there's a syndrome that's called the somnolescent syndrome. And we saw this in particular with the 6-week radiation approach. This cut back when we went to the 3-week approach because it was just a bit more gentle and it got through the treatment faster. Now the hair should grow back and the skin will heal, and the aim at this time period is also to get people off steroids because steroids can cause so many side effects and they're valuable, but then we also have to get rid of them as soon as we can. So beyond 3 months and in the longer term, the main side effects that slowly occur over time are in thinking, and it's mainly in cognition that short-term memory is affected, not so much the long-term memory. Slower thinking speeds and more time for judgment processing is not uncommon, and it does worsen as the years progress. But a situation where it's like a Alzheimer's situation or complete dementia is actually quite rare. The radiation tends to have some effects, but mainly on the short-term memory. Now, the radiation itself can damage the brain tissue called radiation necrosis. That occurs in about 5% of the time. Sometimes because of that inflammation or necrosis that occurs, tumors can actually look a little bit worse in the short term, and that's called pseudoprogression. So somebody at 2 months when they have their scan, oh my gosh, the tumor looks bigger, but that's just the radiation effect and it settles down very nicely. So we've recognized this as a phenomena of our treatments. So I wanted to kind of move into where we are kind of at the current in terms of the radiation technologies and the future. But the major technological advances that have occurred at this time involve IMRT, or intensity modulated radiotherapy. And here the radiation is delivered with the ability to sculpt the radiation in ways that we've never been able to do before. This requires a beam shaping device called a multi-leaf collimator and many beams in many directions. The other major advance is called image-guided radiotherapy, or IGRT. And here it's what I showed you before is a CAT scanner actually built onto the unit, and we're taking pictures right before we treat people to ensure the highest level of precision possible. So I wanted to touch base in terms of first IMRT and IGRT. These advances have changed the look of our units from these radiation units of the past to much nicer looking units of the present and future. But beyond some of the niceties, there's actually a multi-leaf collimator in the head, and again, this is an actual CT device. Now I'm going to play you what a multi-leaf collimator does. So I'm just going to click it on. So essentially what a multi-leaf collimator is, it's a device, and these leaves are actually moving in and out of the beam while it's being delivered. So it's maximally open where there's tumor and minimally open where there's critical tissues like normal brain tissue. And we're using multiple beam directions, multi-leaf collimators, and ultimately we can actually spare areas of the brain much better than we have ever before. So when we look at one of our older types of radiation dose distributions, which was a 3-field technique, you can see here in the corners where there's normal brain tissue, that all that tissue is receiving the high dose. But now with IMRT, we can actually bend that radiation very nicely to conform around our target and spare more of the normal brain tissue as possible. And in one slice, you may say, well, it's not so bad. But when you think about a volume, that actual amount of normal brain tissue sparing becomes highly significant. This is just a different view. It's a coronal view. So again, what you can appreciate, we were really not that great in terms of shaping our radiation with the older technique, but now we can bend that radiation very nicely around the tumor and spare it as best as we can, spare the normal brain tissue as best as we can. Now the other major technical innovation is IGRT, so image-guided radiotherapy. So again, in radiation therapy of the past, we really depended on two-dimensional image verification. So when we're ready to shoot the beam, we take an X-ray basically, we'd see the bone anatomy and we'd say, okay, we're in the right place. And there's, we can see the head, but we can't see the actual tumor or three-dimensional information, but we're good to go. We made appropriations for this lack of image guidance by big margins of uncertainty because we didn't have that level of precision with this type of verification. And this comes about with the advances in image guidance in the use of cone beam CT. So I'm just going to play this video. So essentially what happens is we have this CAT scanner that rotates around the patient, so it's on the linear accelerator, and we're able to take a CT image. So now we're talking about three-dimensional verification. So what you can see here is that the patient is at the time of simulation in this position. Now on the unit, so about a week or a week and a half later when we're ready to treat, we can see that there's misalignment. And this misalignment means a lack of precision. But we have the ability now to make the adjustments because of this information, verify that we're actually completely on target, and go ahead and treat. And this has allowed us to reduce those margins of uncertainty that also translates to less normal tissue being irradiated. So again, major advances that have occurred in the last 5 to 10 years in radiation delivery. The question is, with all things, we have all these fancy things, and just like computers, we have all these fancy things on computers or phones, but what's the real value? Is it just all for show, or what is the role, in particular for glioma, of this new technologies? So if you think about it, you have now this ability to sculpt radiation around your target, minimize normal tissue, and ultimately you can either use this to escalate the tumor dose, so to deliver higher doses of radiation than we've ever done before, or to maximize sparing of the normal tissue and give what we gave before, or potentially both. So I wanted to show you some data first on dose escalation. And these are some this is a Canadian study led by Louis Suhami and McGill, where they took 60 gray of radiation for glioblastoma, so very standard dosing, and they added on a boost anywhere from 15 to 24 gray. So these are very high doses of radiation. They're maximizing the technology at the time to give a stereotactic boost. And eventually what we showed was that it actually made no difference by giving these higher doses of radiation. So then with modern radiation, as it came about, we did a study from Michigan that went from 66 to even 84 gray of radiation. So again, very high doses of radiation using modern radiation technology, and it made no difference over historic controls. And I think we can say in our field that it's not a dose issue. You want to give enough that's appropriate, but then combine it with the chemotherapy, because it's all about attacking it in different ways. It's not one sole modality. As long as you've got given what you need to give, I don't think there's much of a role for giving more in glioma. There are some situations where there is a role, though. So what about the second aspect of using this technology, modifying the late effects? So when we're talking about using the technology to spare areas of the brain, the question becomes, well, what areas should we avoid? And there have been some instances and thoughts about sparing particular areas, for example, the neural stem cell zones that are periventricular, or the hippocampus, which is involved in memory. And it's been very interesting in terms of thought experiments of doing this. And we have been trying this in some degree with some limited success, but we don't know still whether or not it makes a difference. So the way that I do it, say for example in this case, is I will treat my tumor as best as I can and not compromise our tumor coverage, but I'll draw the hippocampus out and bend that radiation as much as possible away from there, because theoretically it may affect memory, and why not do it? If I have the technology, we'll do it in every case. And so this is where we're kind of at with the sparing of normal tissues. We don't yet know what is the most appropriate organ to spare. So the practical applications of modern radiation technology in glioma treatment planning is really unknown at this time. We do attempt to spare the hippocampus, but not at the expense of tumor coverage, because still at the end of the day, our primary aim is to control the tumor. It's controversial. For example, in the neural stem cell zone that I showed you, there was this thought that, if we spare the neural stem cell zone, then those neural stem cells can repair some of the radiation damage. But then actually one series looked at their outcomes and said, well, maybe we're not doing the right thing because they're cancer stem cells that live there. So you have to be very careful when you're thinking about what to do and not potentially deviate so much from the mark, because those patients actually did worse. So we're in a constant state of research and development. So it is a focus of further research. And what I say, based on what I've shown you, when people ask me, well, if I don't have IMRT or IGRT, am I at a disadvantage? I would say no, not in particular for glioblastoma or gliomas, because we still don't know what the application is of a lot of this modern technologies. There may be some marginal gains, but still no one's at any frank disadvantage where you have to travel to a different country or a different province to get some of these technologies. But there are some special cases where you may be at a disadvantage, and I'll show you one of them. So this is a patient with a chondrosarcoma. So this is a benign but aggressive tumor of the brain. So you can see very extensive tumor here, very hard for the surgeons to take this out. They debulked the tumor, so they basically made the patient better by taking out some part of it, relieving some of the mass effect and the symptoms, but now we have to treat this. So in this type of patient, we know we need more than standard doses of radiation. So I treated this patient with 70 gray and 35 fractions. This is a dose escalation, and which is needed for this type of tumor. And you can see I used the technology beautifully, wrapping the dose around the target, sparing as much normal brain tissue as possible, and really creating a very sophisticated dose distribution. And we couldn't do this with radiation of the past. It's only with IMRT and IGRT that we can do this. We used to have to send these patients to Protons, and they'd travel to Boston or Florida and spend weeks away from home, and potentially delays because of delays of actually using the machine. And we don't have to do that anymore with modern radiotherapy. And this is the patient 6 months later, 18 months later, and 36 months later, and she continues to do well. So it's just proof of principle that with modern technology, that there is a particular subgroup of patients that really need it. And your oncologist and radiation oncologist would know who those patients are. There are some, this is an exquisitely radiosensitive tumor, so this type of response was not unexpected, although it was a little bit better than I thought. But there are some tumors like chordoma where you still have to push the dose as high as you can, but you won't get this type of response. But at the end of the day, we have the tools now to treat in ways that we would never be able to do before. So I want to touch on protons because a lot of people ask me about protons. And protons, really had a role before the advent of image-guided radiotherapy and IMRT. And these are massive installations. I mean, these facilities span blocks, not just buildings. They are massive installations with multiple cyclotrons, and they have to accelerate the particles. I mean, it's just a major $150 million device. But ultimately, they have a very interesting characteristic. As opposed to radiation dose slowly drifting beyond the target, the radiation actually stops very abruptly after the target, and it controls the exit dose. And this is the advantage of protons when before we really couldn't manipulate the radiation beam. But still, at the end of the day, protons were still based on X-ray verification. Like all this $150 million unit and all of this technological advantage, and we're still basing it on an X-ray. So the margins were actually very large for uncertainty, even though they have this beautiful ability to stop. Now, just as protons, just as linear accelerators have gone through major technological advances, so have protons. And that technology has also improved. They've added cone beam CT units onto their units, and they've developed intensity modulated proton therapy. So now they can also modulate their beam and wrap the proton beam in ways that we are doing with IMRT. So just in the past, what you would do is you'd get a pretty non-sophisticated dose distribution, but really very little radiation dose outside the target, to now really wrapping that radiation around your target with intensity modulated proton therapy. So there is a question as to whether or not protons will be dominant again, but at this time we don't know. In fact, there are no data to suggest that protons do anything different than intensity modulated radiotherapy for any disease. But there are some theoretical advantages, in particular for children. And at this time, although we don't have the evidence, there is logical benefits in certain diseases for children when we're dealing with extensive fields of radiation, not necessarily small fields of radiation. But when we're delivering craniospinal radiation, for example here with photons, there's this low dose of radiation that gets transmitted into the patient's body, as opposed to protons where it's really quite minimal. So there's this theoretical benefit that we would reduce the incidence of secondary malignancy, so radiation-induced cancers that could develop 20, 30 years down the road. And so this is an important consideration with children, and probably the only area that's indicated for protons at this time where there's reasonable amount of thought evidence, not necessarily clinical evidence, because the clinical evidence have really not panned out in this way, but if you can do it, the principle of not irradiating normal tissue as best as you can is always there. So I wanted to flip gears because we talked about intensity modulated radiotherapy and fractionated radiation and technologies and protons to the use of radiosurgery. Because radiosurgery is a very different form or application of radiation, and it requires, again, very specific technologies. So what is radiosurgery? Radiosurgery typically refers to a single high blast of radiation that's directed just to the tumor. So we don't want to treat any normal tissue because it would be unsafe. And just like a surgeon who wants to go in after just what he sees, we want to treat just what we see. So the intent is to treat only the tumor and none of that margin of normal tissue like we want to in glioma. We want to treat that 1.5 centimeters beyond the tumor. Here, we don't want to do that with radiosurgery. It would be unsafe. So these high doses of radiation are not safe on normal brain tissues, but they are ideal for benign brain tumors and brain metastases because they're small and we don't want to go beyond the boundaries that we see. So this is just a patient with an acoustic neuroma. So again, this is a benign type of tumor. And this is and radiosurgery for acoustic neuroma had made a massive change of practice. I mean, this was really a revolution for this disease because surgeons were going in there, patients would lose their hearing right away, they'd lose potentially their facial nerve at rates of 30 to 40% because it's just such a bad place for surgeons to go into. And then came along some groups that started developing radiosurgery, and you can see we can wrap that dose of radiation exquisitely around the tumor, minimize the dose to normal tissue, and we have changed the game for acoustic neuroma, where patients still will lose their hearing slowly over time, don't have the risk of facial nerve dysfunction, and are basically living much better than with surgery. So this is just an example of my patient I treated in 2005. 2007, it's shrunk down a little bit, and everything is pretty much dormant. Now, you may not see, and you usually don't see, those major reductions in the size of the tumor because, as I mentioned before, what radiation does, it works when the tumor cells try to divide. Now, benign tumors are not trying to divide every day or hour like a cancer cell, but maybe every 6 months. So you get this delayed effect in terms of tumor shrinking because when the cell tries to divide, that's when it ruptures. Or it may just not divide and the tumor cells have been treated and it may just stay stable and dormant, which is really what we want. What we want is no growth. So again, unlike glioma, when patients present, often we're asked, can I get radiosurgery? The answer is no, we don't want to treat you with radiosurgery because we would do you harm. We wouldn't be treating those microscopic cells that we know we need to treat in order to give you as best control as possible. So who gets radiosurgery? Well, it's used to treat, again, tumor only, no margin. Small tumors, because the larger the tumor, it can be a little bit unsafe on the normal brain tissue. And again, high doses of radiation are not tolerant to normal tissue, so we're targeting just the tumor. So we treat it in malignant disease and primarily brain metastasis, in recurrent brain tumors, because there we don't want to expose the normal tissue to another course of 6 weeks. We want to treat just what we see. So benign tumors like acoustic tumors or meningiomas, and some neurologic conditions we actually treat with radiosurgery, like tremor and tic. But this is specialized. So this is where you need specific radiation machines. So radiation machines with excellent accuracy, spatial target localization, where we have used traditionally a surgical head frame. And so we actually screw on a halo onto a person's head in order to do this treatment. But now we've actually got some advances where we don't need to do this, and I'll explain to you those advances shortly. So there are different devices. There's Linac-based radiosurgery where we put this cone on that shoots this very small beam of radiation to the patient's tumor. There's gamma knife technology. There's CyberKnife technology, which is a miniaturized Linac. So we took that big machine and made it compact and put on a robotic arm. This robotic arm was actually from the Ford factory. I mean, that's where it came from. It was actually used for automobiles and then adapted to put a linear accelerator on it. It really is quite an amazing unit, but ultimately, all of these units are doing the same thing. So it's just marketing, Pepsi versus Coke versus President's Choice. I mean, at the end of the day, they all pretty much taste the same. Now, what is different is the frame. So a lot of these technologies still require the frame, and we moved outside of putting patients a frame because it really is very painful for people when it gets put on and when we take it off. The process traditionally has been put the frame on, take the MRI, or we used an MRI a couple days before. Then we're doing all this planning. It's all very rushed because we got the frame on a person's head. We want to get this thing off the patient because they're really not happy. So we're doing all this technology. We're doing all of this work, zap the tumor, take it off, and the patient goes home. So it's convenient in the sense that it's a one-day procedure, but it's a big deal. So now with frameless situations, we're actually changing this. So we actually now, and at Sunnybrook, have adopted completely a frameless situation as long as their dentition is okay. Because what we do is we have this bite block, which is made specific to the patient's hard palate. So they bite in there, we make this bite block, there's a vacuum device that suctions it to the hard palate, and we put the person in the frame, and we get equivalent rates of precision as if we screwed it on. So just like technological advances are occurring in radiation units, surgery, we've made these advances in head immobilization as well. So now the workflow is totally different and it's so much easier. I mean, I used to be in the cancer center till 10 o'clock at night, 3 days a week, doing these procedures because they would have to happen after hours because we're putting the head frame on, we're doing all this work. It really did take quite a bit of toll when you're talking about 3 times a week. So now the patient comes in for MRI as an outpatient. They come in for a bite block as an outpatient. They come in day 2, so the next day, for their treatment. So we have all the time to do the radiation planning, and they come in at 2 o'clock. You know, we give them a time, and it's all set up, and the radiation treatment gets delivered. So much easier on everybody. And in essence, now that we're moving towards multiple metastases, we're not treating just 1 or 2, but 5, 6, or 8, or 10, that treatment can take about 4 hours. So what we can do actually, because we have a relocatable frame, one day they come in, we treat 4, the next day they come in and we treat the other 4. So making everything much more easy for the patient and for the radiation department and for me to get home at a decent time. So this is our Sunnybrook frameless brain surgery unit. So it's very nice. All the bells and whistles are on there, and we deliver frameless radiation. Now, this frameless radiosurgery has really also expanded our ability to exploit still the advantages of fractionation. So still giving it over a big blast of radiation, but over a few days. So take advantage of that day between treatments where the normal tissue is healing. So now we can treat big volumes that we couldn't before, but treat it with 1, 2, 3, 4, or 5 treatments. So that's called stereotactic radiation therapy. Now this can be very good for recurrent glioma because there the tumors tend to be big, non-amenable to single fraction radiosurgery, but we can give 5 fraction stereotactic radiation. So it's very, very elegant and is becoming increasingly used. So it's convenient, effective, and we can actually also combine this with chemotherapy. Now at Sunnybrook, what we're planning to start and in the works of planning a clinical trial is for patients with recurrent glioma to actually put in some chemotherapy wafers at the time of surgery and then follow it up with hypofractionated radiation with chemotherapy and then chemotherapy thereafter. So really trying to take on surgery, implanted chemotherapy, hypofractionated radiation, adjuvant chemotherapy, and putting all the guns on it to try and control recurrent tumors because recurrent tumors are just so hard to control. So this is a patient of mine that I'm doing right now. So in 2008, she had anaplastic glioma. You can see here is no contrast enhancement as we expect with anaplastic tumors. 2014, she's recurred. So I treated her with radiation at this time. And now you can see this contrast enhanced recurrence. Now this is not where a surgeon wants to go. This is dangerous. This can leave her with major deficits. In fact, we can't even biopsy. But all the characteristics are consistent with recurrent tumors and there's been growth over time. So now what I've done is I've created a hypofractionated 5-treatment radiation plan, zapping just what we see with minimal margins, maximal sparing of the normal brain tissue, and we're treating her with focused radiation. So we control that growth that got out of control and give her chemotherapy to help the rest of the brain be controlled for as long as possible. So really emerging, increasing use of our technology and new indications. In fact, the Memorial Sloan Kettering in New York has taken this a step further. Most of us use this only in the recurrent setting, but they devised a protocol actually looking at 5-treatment radiation in the upfront patient. So everything I just told you, 6 weeks of radiation, they threw it out the window and they devised a scheme in order to deliver the radiation even to the normal tissue with 5 treatments. Now, it's controversial, it's preliminary, they've published their first data, it looks pretty good, and so there's promise, and eventually what we will see in radiation oncology as we gain more data is the fewer and fewer treatments, so getting away from 6-7 weeks of treatment down to a reasonable period of time with the same efficacy. And this movement is starting, and it will be the future of radiation oncology. So I kind of want to leave you with just some of the newest inventions or applications of radiation technology, which is really starting to emerge at this time right now. So in the past, as I showed you, we went from regional verification with older units where we look at an X-ray, make sure where we are, and go ahead, to the use of CT scanners on our linear accelerators. And now we have 3-dimensional organ-based verification. So we can't see the actual tumor itself, but we know we're in the right place with increased precision because we can see the bone and get 3-dimensional information. To now what will be soft tissue matching. So with an MRI and a linear accelerator incorporated onto the MRI, we can now actually visualize the tumor itself, make sure we're targeting the actual tumor, not just using the bone as a surrogate, and deliver the radiation. This is going to make a major impact in terms of radiation delivery. This is different than anything before, protons or regular radiation. This is real soft tissue adaptive radiotherapy. And at Sunnybrook, we're actually one of 6 or 7 global consortium members developing this technology. We hope to have this in a few years, and its pace is going along very nicely. So this is the future of radiation delivery, now using MRI with linear accelerator delivery. And this is just a schema that shows you that our aim, it's got a prototype right now. It is in the process of being built, and we are looking at soft tissue matching with unprecedented detail in terms of radiation delivery. So in conclusion, there certainly are a lot of new innovations in radiation oncology. We have made major gains in the last 5 to 10 years, and there's more to come. The role of these technologies is still somewhat unknown, and we're looking at the same tumor control and less side effects as the goal, potentially greater convenience with stereotactic radiation as opposed to 5 to 6 weeks of fractionated radiotherapy, and single fraction radiosurgery certainly is an option for selected tumors and indications, but not necessarily for glioma in the upfront setting. And we'll see where that goes, but at this time, the safest approach is to treat with 6 weeks of radiation. And that's great. Thank you very much.